Hi, this is Dr. Mark Sell from the channel Therapy for the Heart. Today I'm going to have the 8th talk in a series of talks on what makes for a good psychotherapy session. 8th talk, but there was one talk which doesn't have a number on it, but that was a recent talk on Bill Wilson and a DVD that's coming out. So you can look for that tape on the video channels. Today I'm going to talk about the importance of the therapist's feelings in psychotherapy. I have a long-standing interest in this going back to the 70s. And at that time I was working with a patient for about 5 years in analysis. I saw her 2, 3, 4 times a week. And it was a very arduous treatment from which I learned a lot the hard way. And that's the best way to learn sometimes. She was a wonderful patient. She made a lot of progress. She ended up going to school, getting her diploma. That's the end of it. In the beginning, it was a honeymoon stage of treatment, and then that was it. That lasted very briefly, and for the period of about 2 years, I was continuously attacked by this person as being absolutely of no worth to her. I couldn't do anything for her. Nothing that I ever said or did meant anything to her at all. It was just a matter of me being an incompetent person. Parentheses, just like her mother. My problem was this in the beginning, is that I was trying to help her too much, trying to interpret, trying to do all sorts of things that a beginning therapist, I was sort of beginning in the 70s at that time, all sorts of things that a beginning therapist would do without having an awareness of what was happening inside myself. So I had a supervisor named Alma Bond, and that name may be very familiar to some of you, but anyway, I walked into her office one time and she asked me, well, how are you feeling towards this patient? And I had been discussing the patient for a while with her, and I said, thoughtfully, I said, you know, I hate her. And that was the beginning of a lot of things that happened in this treatment. Along with that, I saw Andre Green at a conference in the 70s, and he was talking about a patient that seemed to be the identical patient that I was working with. His patient, her mother would force her to eat tomatoes and rice, and my patient's mother would use that same phrase, tomatoes and rice, and she would force her to eat at the table. That's how much of a control she was trying to exert on her daughter, according to her own, I think, narcissistic needs. So, in any way, I asked Dr. Green in that conference. He said his patient would take in surreptitiously things from him behind his back, but couldn't openly take anything in. He meant interventions and interpretations. Well, maybe that's one of the problems. There were too many interpretations. But in any case, I asked him in the conference, being a young person with a lot of curiosity and some competitiveness, which I still am in a way, but that's okay too, because I remain to be curious. I'll try to work on my competition. But anyway, I asked him a question. I don't know how young I was. I'm not going to say right now. But anyway, I said, was there a countertransference problem in this treatment? And he said, yes, there was, but he didn't elaborate. So as I thought about it, I thought about surreptitiously taking something in and how her mother would try to be one with her, and she hated that, but she liked the notes that her mother would write to her as a matter-of-fact daily events. It really made sense to me. So that I put that together with her mother's ability not to hate her, but she really acted out with her patient and abused her because she really couldn't accept her own hatred towards her daughter. There was a difference in the sessions after I partially resolved my feelings towards my patient. I had some acceptance. I wouldn't say it was totally worked out. I think things are always worked out over years, and it takes a long time. But here's what I felt at the time. Without trying to help her, I was silent. My attention drifted from Jane to the furniture, to the textures of the fabric in the room. I didn't care if she talked. I drifted to the noises outside, and I watched the way the sunlight played about in the room. In the infrequent moments when she would speak, I responded, but for the most part I was silent. She seemed less tense than usual. I felt connected, then disconnected from her. I was calm and experienced a sense of freedom. She wrote me a note. I'm afraid to tell you this because you might blow it, but don't talk. When I left the session, I was furious. I thought of getting hit by a car and then felt like throwing a brick through the window. Then things were floating around in my head, giving, taking, abandoning, and sinking. Then I thought he did give me something. Myself. I didn't feel better after therapy, but different, less despairing, hopeful. I felt better after therapy than I have in months. I don't have to fight off feeling close to you because I don't feel close. Even though we are definitely separate, we are part of a whole that is in fact happy. Now, there's a lot in those few sentences. I'm not going to go into that. You can actually look up the paper and read it. But essentially, I'm looking at my notes here. I got a little lost. But those quotes are taken from a paper that I eventually wrote and was published in 1994, based upon all the work I did with her in the 70s. Published in the 1994 in the Psychoanalytic Review, called Stalemates in Therapy and the Notion of Gratification. Basically, three things, 3 points in that paper. Patients need to be gratified, and how you gratify them is very important, but they need to be gratified. The therapist also has to resolve his or her resistance, countertransference resistance. And what that means is the therapist's feelings that the therapist is unaware of, but then tends to act out. And my patient essentially became aware of her terror of being loved and changed from no one could ever love her to I'm frightened of being loved. The theory of Dr. Hyman Spotnitz on other videos that I've had on this site really applies here, because he was talking about the mother's inability to tolerate aggression from the infant, which makes her mental illness. And Jane's mother could not tolerate her hate, so she ended up abusing her daughter. The paper's on the bio section of my website, marksell.com. Continuing my research into the patient-therapist relationship, I moved from moved into the erotic and the libidinal aspects. And I did my research on the incidence of erotic countertransference, is the name of the paper, and clinical social work practice, a national survey of psychotherapists' sexual feelings, attitudes, and responses. And one of the things that was interesting in that paper was that on the East Coast, many social workers reported, in fact, having erotic fantasies towards their patients. And in the Midwest, they reported significantly much less of that incidence of those feelings, but yet tended to hug their patients more. Interesting. Another person comes to mind that I work with in terms of countertransference and therapist feelings towards a patient. Worked with this patient for some time, and one particular thing stands out in my mind, that on one of the days on the way to sessions, he said he felt like using cocaine. And he said he didn't. He didn't use it because he wanted to come in and talk to me about it, but he had an impulse to use, and also his impulse was to destroy the treatment, which what I call a treatment destructive resistance, but also what Dr. Lucas would call the therapist retreatment, a therapist destructive resistance, because he wants to tear down not only the therapy, but also the therapist who is a stand-in for the incompetent parent. So he told me about this on the way to the session. He said, it was all related to the previous session that I had with him, when he felt that I was not paying attention to him. And he said, well, I know it was that was me. I don't think it was you. And I thought about it for a moment, and I remembered the session, and I said, no, I remember being preoccupied in that session, and I really wasn't with you. And at that moment, he looked up at me and he said, Dr. Sell, I want to thank you for saying that, because my father would never admit to having any responsibility in what happened between us, and he started to cry. It was a very moving moment, and again, admitting to myself and to him that I was narcissistically preoccupied. I was off in another world for those moments in the session, and that enabled him to talk about his feelings towards his father. He said one time, he said to me, the more I feel angry in sessions, the less of an impulse I have to use crack, which establishes again the aggression, the negative interjects which my patient had, and I was able to elicit a lot of the negative feelings that he had towards me, part transference, part reality, and that helped him deal with his cocaine use. The last example comes from working with a woman who this is implementation of good social work practice and modern psychoanalysis. But I worked with her for a number of years. She was an alcoholic who hadn't been out of her house in 2 years, and I visited her many times. I had the freedom to do that because of the agencies to give me that responsibility, give me that freedom. I was a supervisor there, Lenox Hill Neighborhood Association, and so I made many visits. And one of the things, though, that I noticed was that many people were trying to control her, and with rightly so, because she had a prescription for a sleeping pill that could have killed her if mixed with alcohol from her doctor. So anyway, I had experience in alcohol treatment, so I helped her stop drinking, and one of the interventions I had, so many people were trying to control her, so I said, maybe you'd feel like telling me, just mind my own business. And she says, as a matter of fact, I do feel like telling you that. Then I backed away, and the more I backed away from trying to get her to stop drinking, the more she attempted to stop drinking. And one of the things was that she said that I think I would feel better about my incontinence, because I told her that her incontinence was somewhat related to her drinking a lot of alcohol. So to make a long story short, social work interventions and modern psychoanalysis fit there, because I did elicit some aggression towards me. I was also, that was a slip towards her, and I forgot to mention this. I was angry with her, because that was a slip of the tongue, but it was a good one, because it brings me to this point when she stopped drinking, and then she started again, and I was insulted because all of our good work together for I don't know how many months, I felt went down the drain. So I poured her alcohol, her bottle, and I took it and I poured it out into the sink. And after I did, I said, oh my God, what business do I have? This is up to her, not up to me. If it's more up to me, it's not going to come from her. So I went back and I apologized to her, and I said, I'm really sorry for pouring your liquor out, and I offered to go and get her another bottle. And she said, no, I don't want you to do that. My worry was that I lost a friend. So very emotional. So anyway, we repaired that, and I took her out for the first time in 2 years in her wheelchair. She hadn't been out in 2 years, and she said to me, I'm getting people hungry. And she was really starting to replace her hunger for alcohol, for her hunger for people, and also for her hunger. Because of the contact with me that developed over time, we became very fond of each other, and I was very gratified to see that I was able to help her. And I like working with the elderly, because I had an Aunt Marie when I was very young who stabilized my destabilized home life in part. So that's it for now. I want to thank you again. The relevance of the therapist's feelings towards a patient are very important. In my paper on the incidence of erotic countertransference, that was because many papers at the time would focus on blaming the female patient for erotic transference without taking into consideration at all about what the therapist problems were in dealing with erotic feelings of a patient. And that was very important to me. So we got aggression and the libidinal, erotic and hate. Very much becoming aware of those feelings on the part of the therapist is essential in helping a patient resolve their resistances to communication. So on this channel, I hope you can subscribe to it. There's a button on the video on the screen that says subscribe. You can click that if you'd like to. And also, if you'd like to like the channel, that would be great too. Or if you don't have that friendly feeling toward it, you can dislike it. But I do hope you come back. And I enjoy doing these videos. And if you want to leave a comment, you can. And I will respond to it. And then also a reminder on the top of the screen there, it says videos. So if you want to see all the talks on what makes for a good psychotherapy session, click that videos and it'll take you to the playlist. And on the playlist you'll see a place where you can click what makes for a good psychotherapy session. So thanks a lot. This is again Mark Sell signing off. All right, take care.